Good evening, Sujoy sir. Good evening, Archit sir.
Good evening, ma'am.
Good evening, Archit.
Hi, Gopi. Hello.
Hi.
So nice to see you. Thank you.
Good evening, Puri ma'am.
Hi, sir.
Yes. Okay.
Hi, sirs.
Hi, Purvi. How are you?
All good, sir. I panicked like anything some time ago. Then I sat down. I was like, okay.
You are doing really good. Why are you panicking?
Arey,
Fine.
sir. Today, full day, I was like really panicking. Then I even texted Gopi sir in panic. Then I said, okay, no, I will join. Sir, you choose very difficult topics, sir.
No. Actually, I saw their schedules. I felt every time it was AML, DLBCL, AML, DLBCL. Oh, सब सुन के इतना बोर हो रहा था. So I felt we should at least do something, what it is missed out. So that is why I chose this topic. I mean, again, it's very rare.
Yeah,
So
sir.
at least we get a chance to read. So that's why I chose this topic.
Yeah, I know. I was sitting and trying to read yesterday. Then I was sitting and wondering how many patients I've seen. Then I was sitting and wondering how many patients I've missed. Everything lytic should not be considered as, myeloma. We think along lines of myeloma, we think along lines of everything, but we tend to forget adult LCHs.
Sure. Subhashri, can we start? I think almost most of the panelists have joined. So
Yes, sir.
can we go
We'll
live?
start.
Yeah.
Yes, sir. Nakul sir, not able to join because
Okay.
he's
Dr.
trouble.
Dr. Sujay I saw Dr. Sujay transiently, but now I'm not able to see him.
Yes, sir. Sujoy sir already there.
Sujay, I'm not able to see Sujay. Sujay is there? Yeah, Dr. Sujay is there. Okay, then we
We'll
can
start.
start.
Okay. So, good evening, everyone. On behalf of the International Association for Integrated Oncology, IAIO, it's my great pleasure to welcome all our esteemed faculty members and dear participants to today's IAIO Expert Insight Hemato-Oncology session. We are honored to have an esteemed group of experts with us today who will share their valuable knowledge, clinical experience, and practical perspectives on this rare and challenging group of disorder. It's my privilege to welcome our program director and moderator, Dr. Gopinath M, consultant hemato-oncologist and BMT, MGM Cancer Institute, Chennai, to deliver the welcome and introduction and set the context for today's discussion. Over to you, sir.
Yeah. Okay. Good evening, Team IAOO. First of all, thank you very much for the opportunity for us to give a platform to meet our fellow colleagues and juniors. I think IAIO is doing a very good job of conducting this weekly webinars and monthly webinars to just keep the oncology graduates upgraded. And I think people should keep doing it on and on. So the topic that we chose for discussion today is adult LCH. I know it's quite a rare topic that, even in institutes, we see it pretty rare, where the patient load is quite high. It's not so common as like a childhood LCH. So that makes us, this topic more inquisitive and more to read. And so that if at all we come across this case in a OPD, how to go about. So that is why I chose this topic. And we have an esteemed panel with us, starting from Dr. John, Dr. Archit, Dr. Venkachalam, Dr. Puvi, Dr. Harshal, and Dr. Sujay. So I think we are going to have a good introductory note by Dr. John Abraham first, and then followed by a very good panel discussion. So now I introduce and welcome Dr. John Abraham, who is just going to give the topic overview about adult LCH. Over to you, Dr. John. Dr. John Abraham is a clinical is an assistant professor, Department of Clinical Hematology, from CMC Ludhiana. So over to you, John.
Uh,
Thank you very much for the introduction, Dr. Gopi, and thank you very much for giving me this opportunity to present Langerhans cystitis. Like how the rest of the panelists have described, it's a very rare disease. So I'll try to in the next 20 minutes give a brief overview and set the stage for good discussion amongst the panelists. So without much ado, let me go into the presentation. So just a brief introduction. It's an inflammatory myeloid neoplasm, LCH. It's most commonly affecting the skins and bones and can also involve other systems. Just wanted to confirm, I hope everyone is able to see my slides.
Yes, we are able to.
Yes.
Okay.
Yeah, we are able.
Yeah. More often presenting in children than in adults. The neoplastic cells, it's resemble the dendritic Langerhans cells in the skin and mucosa, hence the name Langerhans cell cystitis. It's a clonal disorder of malignant myeloid cells that is driven by the activation of the mitogen activated protein kinase, MAPK ERK, that is extracellular signal regulated kinase signaling pathway. 50% of the cases usually have mutated BRAF V600E mutation, and rest of them have other mutations, other components of the other components, which is maybe downstream. The cell of origin is malignant Langerhans cells, which is derived from the myeloid dendritic cells. So this is the map MAPK pathway, and the mutations can happen right from BRAF mutation to MEK to ERK mutations. So anywhere in the pathway, mutations can happen and can lead to the LCH. So what are the pathological findings? What are the main pathological findings? The overall, the histology has sparse Langerhans cells composed of inflammatory cells. There might be fibrosis. The morphology is large oval cells with eosinophilic cytoplasm, grooved, folded, indented nuclei, which is characteristically having a coffee bean or twisted towel appearance. The background infiltrate consists of eosinophils, neutrophils, lymphocytes, macrophages, and multinucleated giant cells. There are other patterns where eosinophilic abscesses, burned out lesions with low cellularity, fibrosis, and foamy histiocytes are seen. The diagnostic IHC consists of CD1A positive, CD207 positive, that is Langerin, S100 positive, CD68 positive, and it is usually CD163 negative. The BRAF is detectable by VE1 IHC. Molecular testings can also be performed. Cyclin D1 is often diffusely positive. It supports a neoplastic LCH over a reactive Langerhans cells. Hemophagocytosis and myelodysplastic changes may occur but are not diagnostic. The epidemiology, it is more common in children, and in adults, it's more common in males. It is pretty rare, that's why it's probably underreported also. The approximate incidence has been estimated as 5 cases per million in children and approximately 1 per million in adults. So these are the various histiocytic disorder classification as per the Histiocytic Society classification, out of which Langerhans cells is the L type, which is consist of Langerhans cells, histiocytosis, head and chest disease, mixed LCH and ECD, indeterminate cell histiocytosis, extracutaneous juvenile xanthogranuloma. The rest of them I'm not going through into detail. It can be cutaneous and mucocutaneous, Rosae or Dorfman disease, malignant histiocytosis, and HLH. So what are the organ manifestations? The main organ manifestation, that is 30 to 50%, is seen in bones, and it's basically presents as can present as single system, multi-system lytic bone lesion, can be skin involvement, isolated skin involvement in 5 to 10%, or as a part of multi-system involvement, usually presenting as erythematous papular rashes with scaling and crusting. Common sites include chest, back, abdomen, limbs, scalp, and groin. Endocrine is the most common endocrine presentation as diabetes insipidus, which may precede LCH diagnosis by many years, then there can be nervous system and orbit involvement, which is seen in 15 to 20% cases, can be presenting as focal mass lesions in pituitary stalk, hypothalamus, or pineal gland. Can also present as brain parenchyma infiltration, and can also present as neurogenerative LCH, which is quite rare. Pulmonary LCH can occur in 40 to 50% of the cases, and 60 to 70% have respiratory symptoms, usually associated with strong association with smoking. Liver and spleen can also be involved. Bone marrow, lymph nodes, gastrointestinal, and cardiovascular, which are all pretty much rare manifestations. So there are a lot of systems that can be involved in LCH when it comes to LCH in adults. The diagnosis, it's a rare condition, but should be suspected in a patient of any age with an unexplained lytic bony lesion, skin rash, ADH deficiency, pituitary mass, or respiratory symptoms with characteristic imaging. The diagnosis is based on pathological evidence of LCH in the setting of clinical and imaging findings. Pathology confirmation is the morphologic appearance of Langerhans cells corroborated by IHC staining for CD68, CD1A, CD207, and S100. If possible, an osteolytic bone lesion or skin lesions are generally preferred. Clinical findings and imaging. Suggestive findings include a lytic bony lesion, skin rashes, uh, diabetes insipidus, upper lobe predominant lung nodules or cysts in a smoker, and other clinical manifestations. Whenever there is, it's not possible to obtain a biopsy. For example, brain lesions, which is not approachable, and or when the histopathology is equivocal, the diagnosis can be based on characteristic clinical features and imaging. And in such cases, molecular analysis of blood or bone marrow for mutation of BRAF or other components of the MAP pathway can also enhance the confidence in the diagnosis. These are the differential diagnosis, not going into detail, but the just listing out the disorders. Langerhans cell sarcoma, Erdheim chest disorder, indeterminate cell histiocytosis, juvenile xanthogranuloma, multiple myeloma, HLH/MAS, Rosai-Dorfman disease. These are all the differentials when it comes to LCH. Now, brief overview of management. When we have to manage adult LCH, these are the few questions that you need to ask. First of all, is the CNS involvement there or not? If CNS involvement is there, there's no doubt the patient has to undergo a systemic treatment. Next question you're going to ask is it a single system or a multi-system involvement that is there? If it is a single system involvement, is it a unifocal involvement or a multifocal involvement? And then you look at the symptoms. Is this symptomatic high risk symptoms, or is it asymptomatic low risk, which can warrant a local treatment or sometimes just observation? If it is symptomatic and high risk, definitely we would require a systemic therapy. Now, coming to management of bone disease, management of bone disease is based on this, whether the involvement is of CNS high-risk bones, for example, maxilla, orbit, mastoid, temporal, or sphenoid. In such cases, rather than going for local therapy, the recommendation is to go for systemic treatment. If it is a non-CNS risk, the treatment can be local management, which include curettage plus adjuvant therapy, which includes bisphosphonates and other supportive therapy. If there is multiple bone lesions, then we go for systemic therapy. Pulmonary LCH, the main treatment is smoking cessation. 60 to 70% of the patient actually respond to that. If there is no improvement in the imaging and symptomatically, then we can consider glucocorticoids. Even if once the patient fails glucocorticoid trial, you can consider cladribine and other targeted therapy. But usually with these therapies, patients do respond well. This is just 5% or 10% of the patient who will have progressive Langerhans pulmonary LCH and would require lung transplantation. Otherwise, most of them do respond. Skin LCH again, if it is not really symptomatic, you can go for observation or consider topical therapy, hydroxyurea, steroids, 6-MP. In refractory cases, can consider lenalidomide or thalidomide. Whenever there is a CNS or a risk organ involvement, the recommendation is to involve targeted therapy, which is BRAF inhibitors or other MEK inhibitors. But the problem with these is twofold. One is that indefinite therapy or prolonged therapy. And the second problem in our settings would be a very high cost. So in that setting, even though the response rate would be much lesser than the targeted therapy, around 60 to 70%, we would prefer cytarabine and cladribine, which does have a durable and almost 70% response rates. So cytarabine and cladribine are the preferred systemic treatment in adults at least. So cytarabine, this is how we are giving 100 mg per meter square for 5 days every 4 weeks for 12 months. Almost 79% response rates. Particularly, it's effective in multifocal bone disease. Cladribine, a little more shorter. It's given as 5 mg per meter square for 5 days. 2 to 4 cycles is what is recommended. And again, the response rate is almost 80% response rates. And more favored in case of CNS and brain, wherever there is CNS and brain involvement. So these are the treatment modalities which is more preferred in pediatric and is more toxic in adults. So single agent cladribine and cytarabine is more preferred in adult in view of the potential toxicity. But these are excellent choices for pediatric cases. Response assessment in LCH. So it comes to the modality, the preferred modality depend on the kind of disease or the organs which are involved. PET-CT, MRI for GI lesions, endoscopy. These are all the methodology which we use for response assessment. If it is single system disease, you're going to review the symptoms, examine the involved sites, repeat a PET-CT 2 months after curettage of the bone lesion and treatment of skin disease. If it is a multi-system disease, after 2 cycles of chemotherapy or after 3 to 6 months of targeted agent, you're going to do a repeat imaging. The response categories and organ response categories and definition. Complete response is normalizations of lesions with FDG uptake equal to the normal PET scan basically and a normal CT or MRI scan. Partial response is when the PET reduction from baseline SUV of lesion, but there is still a persisting uptake greater than the surrounding tissue. CT MRI, there is a reduction, but complete resolution of the feature lesions are not there. Sorry. And progressive disease is when you have new FDG avid lesions or increased SUV value, and in CT or MRI appearance of new lesions. Stable disease is when you don't meet any of these criteria, then it's stable disease. So to conclude, LCH is a clonal MAPK pathway driven disorders. It has a highly variable clinical spectrum. Diagnosis require tissue confirmation with characteristic morphology and IHC. Staging is critical for prognosis and disease management. BRAF V600E and other MAPK mutation testing is increasingly becoming important. Treatment is risk or organ or stage dependent, ranging from observation to local therapy to systemic therapy. Thank you.
Thank you, sir. Thank you so much for that excellent and comprehensive presentation, for sharing your expertise with us. So we now move to the highlight of today's program, an engaging panel discussion. I would like to invite our moderator for the discussion, Dr. Gopinathan M., Consultant Hemato-Oncologist and BMT, MGM Cancer Institute, Chennai, Dr. Archit Sunil, Assistant Professor, Department of Hematology, AIIMS Nagpur, Dr. Sujoy Ranchar, Consultant Hemato-Oncologist, Ashwath Hospital, Rajkot, Dr. Nakul Dilip Tikare, Consultant Clinical Hematologist, Hemato-Oncologist, Manipal Hospital, Goa, Dr. Venkat Chalam, Consultant Clinical Hematologist and BMT Physician, Vadamallam Hospital, Madurai, Dr. Purvi Kapoor, Assistant Professor, Department of Clinical Hematology, Dr. RML IMS, Lucknow. Dr. Harshal, Assistant Professor, Department of Clinical Hematology, King George Medical University, Lucknow. May I now request Dr. Gopinath M to kindly take over and lead this important discussion. Over to you, sir.
Thank you, Subhashri. May I request John also to join the discussion?
Yeah, I'm here, sir. I just logged in through my phone.
Sure. Okay. Thank you. Welcome, dear panelists. Thanks for accepting the invite and sparing your evening time for creating such an insightful discussion. So let me just share my screen. Yeah, hope my screen is visible.
Yes, sir. Visible.
Visible.
Yeah,
Oh,
yeah, it's visible.
right. Okay. So I had picked up handpicked some cases, again, what we read in books and what we read in guidelines. I think when it comes to practical discussion, we have to have a lot of, tug of war between the patient and ourselves, and what this point of time, how to proceed. The real time confusion arises. So I just handpicked some cases and let's just discuss how I'm going to manage this patient. So maybe I'll just start with the first case. She's a 33-year-old female, 8 months postpartum, actively breastfeeding. She has got a sharp, catchy pain in the left side of the breast, but there are no any visible swelling, erythema, or tenderness. So she goes to her gynecologist. She initially thinks that it was probably some retained breast milk or breast abscess. Manages her with some analgesics, antibiotics, but then there wasn't any relief. Even she gets done a normal ultrasound breast, but it's absolutely normal. There was no frank breast abscess or mastitis or something which was usually expected around that time, but that wasn't there. But the pain was so terrible that the woman is almost not able to sleep. Even for that matter, she was not able to take care of her child, and that is how she presents to a different physician. Probably the orthopedician is the second physician that they usually see. And then they get a chest x-ray, which shows a lytic lesion in the left seventh rib. Okay, right. So following which he also gets an MRI. Again, it has shown a focal lesion in the left seventh rib. So may I just start with Dr. Archit? So if given the scenario, Dr. Archit, so what would be your next line of investigations that you would be asking for in such patient?
Okay, good evening. Thank you, Gopi, for the opportunity. Thanks, John, for the wonderful talk, and thank you for the team. Uh,
Thank you, sir.
so again, as a 8 months postpartum lady with a new onset lytic lesion, it's not normal. It definitely needs workup. Uh, X-ray cannot show usually a soft tissue component, and MRI is showing a focal lesion. So there is no soft tissue component. That is somewhat reassuring, but also worrisome. And as you have mentioned, PET CT needs to be done because it helps us to know the extent of disease. Now, if PET CT is not showing any other lesions, her CBC is normal, then we can safely wait for bone marrow in this situation, postpartum, feeding child, and do that. So now we need to go ahead with biopsy, and we have to understand that these ribs are actually they have an inferior margin of ribs will always have a neurovascular bundle. So these biopsies, post biopsies also, they will be very painful, like typical myeloma. So the child is also feeding. There is also going to be opioid use if we are going to use. So again, we have to see what analgesics will we give. Maybe if tramadol, then we'll have to space out feeding of the baby for some time. And once a staging is done, if we know that it's a single site lesion, then maybe a consultation with radiotherapy, or if we can ask the orthopedician or a CVTS surgeon whether it can be done. RT I read today, I have not experienced per se, I'm sorry, but they have said ki up to 3 lesions, if they're in close vicinity, you can try radiotherapy and should help for soft tissue lesions as well. So that's what I could read. So thank you.
Yeah. I think Archut gave a comprehensive answer. So, yes, maybe we'll continuing discussion with, Dr. Archut. Maybe I'll just put on to Dr. Harshal. Harshal, how do you want to classify this lesion? And what is your usual mode of pain management? I think what's your mode of biopsy? And given that, the various options for, so this lady has a normal CBC, RFT, LFT, viral markers. PET CT wise, there is no lesion dispersed anywhere. She only has that focal lesion. Okay. So what are the various treatment options that you would consider?
Yes, sir. So basically, this particular lesion is since it's involving only one particular rib and one bone, so it is unifocal and it is single system LCH. And for pain management, I would use some NSAIDs. And if it's an unbearable pain, then maybe some intralesional corticosteroids can be tried in this patient.
Right, right. So
Yeah.
now that you have various options, right? You have RT, you have you may still do an intralesional steroid as you are telling, and
Yes,
you
sir.
can just do a curettage and cementing, or you can actually do a rib resection. Which
Yes.
do you feel is more feasible for the patient to take it to for the patient? I mean, for you to convince the patient and for the patient to take it also. Which do you think is
So
possible?
at this point of time, because she's just 8 months postpartum, I will not go ahead with RD. I
Okay.
would rather go with intralesional steroids. If that is not possible, then maybe curettage and later on, if resection of the rib, if that is what is not this, if that's feasible and if patient is convinced, but I will definitely not go for RT at this point of time.
Yeah, yeah. Maybe what do you think are some of the offsides of doing a resection? Maybe I'll put it this way.
So resection as in I'm not completely sure, like because we have never encountered such a case before.
Okay, okay. Okay, fine, 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 no problem. Yeah, right. I mean, it's very rare. So again, for the postgraduates who are listening here, so I agree that you may have the PET CT, you may have all the workup done, but despite that, you still need to do a vigilant skin examination because you may have some accompanying skin lesions which may not light up in a PET. Say, for example, if it is somewhere in the back, somewhere in the vaginal orifice or somewhere in the mucosa, you may actually have a high chance of missing out that lesion where you have two site involvement. So because since these are low proliferating lesions, so always make a point that you always conduct a vigorous cutaneous examination. And I think we are actually spoiled for choices in case of in case of this kind of single site lesion. So since this lady was complaining of so much pain, and I agree, and I take Harshad's point, but I actually have to initiate some treatment first because
Yes.
even if I have to call an ortho, if I have to call a surgeon, it's at least going to take 2 to 3 days time. And the pain, I think it was quite different than the myeloma pain. Even after seeing this patient only, I read LCH pain, particularly when in the periosteum of ribs, is so terrible. It seems they usually have VAS scores as high as 8 or 9. It seems. So what I felt is maybe RT is the one which was feasible for me to initiate as soon as possible. Just she got an appointment with the RT consultant in the afternoon. By evening, her planning was done, and the next day morning, RT was initiated. And obviously, since she was 8 months old, probably the breastfeeding can stop, not much. Whereas if I do a surgery or do some surgical procedure, and I think you may have so many other operative things going on, so I may not be able to continue. Though per se, it is not an active contraindication for the baby to breastfeed. So I felt at least for the immediate pain control relief, RT is something which was what feasible to do. And I think, in a period of 12 days, I mean, with even second or third day, I think she got completely relieved of pain. So and also had it been other way, guys, maybe if the pain was less or not of this much this thing, probably I'd have even gone for a curettage and cementing. So this is what happened with this particular patient, and now she comes to follow up. Almost it has been 1.5 years since she is being treated. And what is the follow-up? How do you guys follow up these patients after you treat? How do you want to follow up this patient? So it's a single site LCH. So I couldn't come across any guidelines. Maybe from your from your own perspective. Maybe Purvi, I can ask, how do you want to follow this patient up, Purvi?
Thank you, sir. Like you mentioned, one is extensive examination clinically for the patient for any appearances of any other lesions like skin lesions. The second thing is, per se, I think the easiest would be to get a follow-up PET CT, and that would be like 3 monthly to 4 monthly PET CT for the patient, just to ensure that there's no other lighting up or there's no other new lesion that comes out. And of course, target organs should definitely be looked at, sir. But clinically, detailed history for pituitary involvement or any kind of CNS or cardiac involvement. Otherwise, I would prefer just doing a PET CT since she had only unifocal disease. So.
Yeah, I think I couldn't find across major, guidelines, but then those case reports or case series said at 3 months you do one, and at the end of year you do one, and then you clinically follow up. Fine. So this is again for the listening postgraduates and fellow colleagues. So this is since in childhood predominantly you are going to get LCH, but in adults you're going to have overlap of sometimes you may get RDD, Rosite Hoffman, and you may get erythema Chester's, which is again very rare. So these are some of the panel of markers that we need to know whenever you approach such an histiocytic neoplasm. So you see CD68, which is commonly expressed in all the three disorders. Because all these are disorders of dendritic cells, they are from the monocyte macrophage system. You see CD68 in all the three, whereas CD163 you see only in EDD. Again, cyclin D1 you see in all the three, right? So these are some of the common markers. But if you want to have disease-specific markers, again, as John Abraham highlighted, you have CD1A, S100, and CD201, very classical of LCH, though you may have some 20 to 30% of cases expressing S100 in Rosai-Dorfman disease also. And again, factor 13A is much specific for ECD, whereas your OP2 is much specific for RDD. So this is since we can have varied histologies coming across in adult histiocytic disorder. So this table is a must go to remember. And again, as the importance of having high risk sites like pituitary, CNS, heart, where even if you have a unifocal disease, you need to treat it systemically. Whereas as Sachin highlighted, if you have a skin focal lesions, less than 3 bony sites, you can actually go in for a less intense treatment. So this case, I would like to, I like Dr. Venkatachalam to take it over. So she is a 36-year-old female. She had jaundice, pruritus for 3 months duration. Obviously, most of our patients before consulting a doctor, they go for native medication, then they go for chat GPT, then they come to one physician, then they come to a specialist. So that is how the patient circuit has been in the last, last 2 years or 3 years. So this is something like that, jaundice, pruritus for 3 months, native medications for a month, on like no loose stools, no other cholestatic symptoms. She just has a muddy conjunctiva, no prominent hepatosplenomegaly. So these are blood counts, 9.3 normocytic hemoglobin, total count 4,400, normal differentials, slightly low platelets 1.4 lakhs, RFT is within normal limits. You can see a conjugated bill. You can see that you have AST, ALT higher, ALP also increased, GGT also increased, kind of a cholestatic picture with mild AG reversal. Imaging, you get to see a sclerotic lesion in the right liver lobe. So, Dr. Venkatachalam, may I just ask you, like, when you get a case like this, you have somebody presenting to you with a conjugated bill, with some kind of a focal sclerotic lesion in the right liver. So, how do you approach? Obviously, you are going to see in liaison with gastroenterologist. What would be your
Yeah.
next go to action?
Uh, in indeterminate cases, like in this one, the biopsy is already done, which is not conclusive.
Hmm.
Maybe we'll have a repeat biopsy from like adequate tissue sample with, and we'll have to go for a repeat biopsy. I feel here because it is not like very classical of LCH. That is what, and the IHC is also like not possible from the tissue we had got. Yeah.
Okay.
So I'll prefer to go for a repeat biopsy in this patient.
A repeat biopsy. Maybe I'll ask all the panelists know
Hmm.
how many times you have had, difficulties, particularly with LCH, to establish a diagnosis. I think all of us would have had that trouble. Maybe I'll ask all the panelists of their individual experiences. How many times you have had? Yeah. Dr. John, your
Yeah, so sir, I have seen 2, 3 cases during my residency, and
mm,
it's been 1 year since I entered clinical practice. I've not seen a single LCH.
okay.
So that's my, I mean, 2, 3 cases I'd seen. One was CNS, and one was bony LCH multi-systemic involvement.
Okay.
Other than that, I have not seen any cases for that.
Okay. Maybe Dr. Suchay, have you come across such difficult to establish diagnosis in LCH, like where your clinical features will fit in, but you're not able to get a proper biopsy?
Uh, like actually, I haven't come across a difficult case, but I would definitely say ki, for some of the cases where there was a multisystemic involvement, so it had taken like long time to come to the conclusion.
Yes.
But I would say if we have a proper sample and get it done at a proper place, so maybe that timeline can be compressed. So
Come.
that's what I would think.
Yeah. Dr. Puvi, you have similar experience?
Definitely, sir. When posted with you only, we struggled with a couple of children.
Mm.
Multiple biopsies, classical presentation for LCH, and multiple biopsies. We would get like inflammatory. First one got reported as inflammatory infiltrate, then went back reviewed. Then we had multiple attempts also, then CD1A expression also, IHC markers, all of those. And even at the time of relapse, we had one patient, one child, and even at the time of relapse, it was so difficult to establish it as a concrete relapse LCH that we struggled for almost 1 month just to be able to establish a tissue diagnosis. So yes, it's very difficult, especially when you get so much inflammatory infiltrate and not the characteristic Langerhans
Langan.
Langan cells, sir. So yes, we've had difficulty.
So I agree. In LCH particularly, this can happen because they are not florid proliferating diseases. We may actually have paucicellular, the malignant cells. The proportion of malignant cell may be very less. So for you to get a proper malignant cell, it's going to be difficult. And again, if you want to put an IHC, the tissue may get exhausted. And patient will be sick simultaneously. So we have all the things happening side by side. So as Dr. Venkat said, in this case, we definitely have to have a proper tissue diagnosis before establishing a diagnosis of malignancy and then treat. So in case, for example, Dr. Venkat, in case if you are not really able to push down for a biopsy, would you, try doing something with the biopsy sample that you have? Yeah, Dr. Venkat is here. Dr. Venkat?
Yeah, I would like to go for a, like, if possible, we might have to go with this one, a molecular diagnosis like BRAF mutation, or if BRAF is negative, then the MAPB pathway mutation, other mutations. But again, there might be like difficulty in processing the tissue samples here.
Yeah. So I think Dr. Sujay, any inputs from your side? Molecular
Yes,
diagnosis.
so I would definitely go for the molecular analysis as fast as possible in such cases. If you're
Okay.
not able to get a repeat sample done, so whatever sample you, I think we should try to go at least get done a molecular analysis.
Okay. So, Dr. John, you were telling about this IHC for BRAF V600E, right? So IHC V
Yes.
thing.
We once can.
So
Yeah.
you do in CMC? You do this in CMC?
In Vellore, I'm not sure, sir. I don't
In
think we
Vellore,
have done. We have just
no, in Vellore we don't do. We send the this one molecular,
molecular.
the one molecular one. Yeah.
Okay. So I mean, for me this IHC V1 stain was something new, which I mean I haven't never done, and even the literature says even if you may get a lot of negativity, even if you get negative, you have to again confirm with molecular. So that's what
Molecular.
Yeah.
molecular is what they were saying, and probably you may have a low VAF. So that is what the literature says. And again, particularly with liver and other solid organs, we may not have trouble, but the main caveat to be noted is if you're going to send it from the bone marrow biopsy block, where if you're going to do if your tissue is acid decalcified and fixed, there you may have a false negative reports. So that is something to be kept in mind whenever you're going to send the tissue block from the bone marrow biopsy. And if it has already been acid decalcified, then we may have false negativity higher. So it's better, to have a non-acid decalcification when we do tissue preparation is what the guidelines recommend. So and again, concordance in LCH and EDD, I think it's more of an entrance question that all of us know the answer. So can someone just, since John, you have presented the literature, can you just tell, I mean, how much is the BRAF concordance in LCH and Earthen Chesters? So
Sir, you're asking how much is the mutation in both of them?
Percentage. Yeah, percentage.
Okay, so EDD, I'm not sure, but LCH, I know that it's almost 50 to 60%. In
60.
fact, I was just about to ask this question because
Uh,
I just wanted to know, I mean, how important is it for us to determine whether it's an LCH or EDD, or is it a Rosidorf? Does it really change the treatment? I was not really sure. I mean, even though I had put it up, but so I just wanted to ask the panelist also. So is it very important to have all of them distinguished, and does the management change based on that?
I think with ECD we can do more of targeted therapy, I feel. But LCH again, targeted therapy is just coming up, and the duration of therapy guidance. And sometimes with LCH we have long-term complications, particularly when the disease relapse. You can relapse in the high-risk sites like CNS and all. So
Okay.
that makes a difference in management. ECD patients are usually very, very sick. Say they come with a lot of this Erlenmeyer flask, effusions, and so on. Particularly with the long-term treatment decisions and these relapse. So I think that is a area where we need to really differentiate between LCH and versus RDD and other ECD.
Okay.
And
Okay. Thank you.
again, this is yeah. And again, this is the glimpse of the data that you had presented. The main difference between adult and pediatric. So pediatric, I think all of us know it is trial driven. Most of them is already there in the trials, and it is solid proof evidence. But adults, we don't have trials, and it is only through case series and some of the larger cohorts that are published. So again, toxicities, vinblastine and cladribine, toxicities are slightly higher than children because children do tolerate it very well, without much neuropathy and all that. Response rates though are really good, but the relapse rates are as high as 40 to 60%. That's what the literature says. So and again, vinblastine prednisolone is a mainstay of treatment in children, whereas it's totally different in adults, where it is more of, as you presented, it's more of a cladribine and cytarabine based regimen. The highest number of evidence I could find is from this methotrexate and cytarabine regimen. So this was from the Texas group. So it has quite a good response rate of nearly 88%. So maybe with this lady having a liver involvement, probably cytosar would be a better go-to choice. Okay. So case 3. So again, maybe I'll ask this case to be taken up by Dr. Archit. Archit, you are here?
Yes, Gopi.
Yeah. So she's a 56-year-old female, vulval itching, non-resolving leukorrhea. So the lesions were increasingly erythematous. So obviously she is not going to visit hematologist by any chance, right? So she's going to go to the dermat, she's going to go to the gynac, she's going to maybe go visit some physician. And by the time, it is almost 6 months, the story is going on, between gynac and dermat, they were cross-referring the patient. So they had a multitude of differentials. Probably STD was the first one to start with, TB was the second to go, and third one was something autoimmune. And this lady had a classical weeping skin lesions over the vulva and vagina, and she had inguinal lymph node involvement also. So, and then obviously, so these were some of the, yeah. So these were some of the differentials that was considered in the evaluation of this patient. STD, age-related, lichen planus, genital TB, Crohn's, but IBD related. So while this was going on, obviously there is one biopsy that is done by the derma department, and then totally the landscape of the disease changed. So in a case like this, Dr. Archit, so when do you think it's crucial for you to have a consultation in between?
Thank you, Gopi. Again, tough choice, but in general, if something is related to vulval lesions and hematology, so it is in general LCH and maybe Paget's disease. So these are 2-3 things which we can see commonly. Now, we need to understand that it is usually an ulcerative lesion, and ulcerative lesions biopsy will always be gotten from the edge of the site. Now, um, as is with all the genital malignancies, the local drainage of these lymph nodes is depending on the site of the vulva where it is involved. Somewhere near the midline has a different site. So, just because on clinical examination also, if we get some inguinal lymph nodes, that does not automatically make it a metastatic one, because the cells which we are dealing with are actually reactive cells. So, again, you have to have some local imaging to see for the size of lymph nodes. If there is asymmetric enlargement of lymph nodes with one side or other, if both sides are equally lighting up or equally swollen, then maybe they could be reactive.
Okay.
Third, then now in such a cases, as with Hodgkin's, we always face a problem of focal lesions, like focal cores. If we take a single core, we can miss the cells. Similarly, in these cases, if we don't have a full excision biopsy, then
Okay.
those crucial areas may be missed.
Okay.
And it is important because depending upon the site, you will stress upon how much detailed staging workup you want initially in the meantime. So
Okay.
if it is a large lesion, you will want to fast track PET CT first and then get a
Okay.
histopathology, and in the meantime start some local topical treatments.
Okay.
Usually skin people usually start with topical steroids, and depending on histopathology you can go ahead. But we should understand the cause of lymph nodes, we should understand the cause of vulvovaginitis, and then the distant metastasis, and an excision biopsy should be done if possible.
So I know, lymph node means always it's excision. So in this case, would you like to do an excision, or if you'd like to have some cores or aspirates?
Always an excision, but if not possible, at least 4 course
Four
through
cores.
maybe I think 16G needle, what they always tell in to answer in Viva. At
Three.
least 3 to 4 course, because it is a very focal disease. You cannot predict which part of lymph node will have a disease. And already in an area wherein we have discussed that tissue is difficult to get, DNA is difficult to extract. So
Okay.
sometimes morphology can be your best friend.
Okay. Okay. So I will tell what I did with this patient. Since she was already roaming between so many departments, and so she was totally frustrated by the time always when I mean by the time she reached. So I didn't ask for excision. So I only asked for course. As you said, I only asked for course. So, but the course, again, course wasn't involved by the disease. It was only a reactive change that was in the course.
Okay.
So, yeah, so that is what I did. I don't know at that point. Obviously, as for PET all actually a classical drainage area it showed. It showed some external layer, but there wasn't any distant sites. Again, it's important to know that when one mucosal site is involved, always other mucosal sites needs to be examined. That we need to involve see the oral mucosa also. Sometimes we may have associations of oral mucosa getting involved by LCH, where I mean, again, that makes a difference. So, how do you like to manage this patient? May I ask Dr. Venkat? Venkat? Yeah. Okay. Or maybe I'll ask Harshal. Dr. Harshal, how do you like to manage this patient?
Uh,
I mean,
so
it's
first
nothing is right
after
here, nothing is wrong here. Maybe you can just put out your choices and then you can tell us what you would like to manage this patient.
Yes, sir. So after the confirmation of the diagnosis
Hmm.
and after assessing the disease extent to what the extent the disease has been in the this has been involved. If it's a localized disease which is just confined to the cutaneous involvement around the vagina or just the genitalia, then I would go with topical steroids or maybe a topical tacrolimus. If it's just limited to superficial this. And if there is an extensive involvement, if it's progressive or if it's involving any other side, becoming multifocal, or if it's refractory to the topical therapy, then I would go for a systemic therapy where I can maybe choose methotrexate, cytarabine, clatarabine based, or maybe vinblastine based if patient tolerates well.
All right. Well, okay. Okay. Yeah. Any different inputs? Other panelists, please can be open. You can tell out your options. Sujay, anything different that you want to manage?
Yeah, so I wanted to ask, like, what is the stage of the disease in this patient?
It was just in the vulva, inguinal, and there was some external iliac lymph node. So that was
Okay. So I think like topical, I would try first. If no response, then I would straight away go for the systemic therapy.
yeah.
Uh,
Lymph nodes. I mean, the lymph nodes we were in, though biopsy came negative, I wasn't really very sure whether it was only inflammatory. I mean, so that was a fear that I had. It was only
okay.
inflammatory, or it was actually disease involvement. But the other sites of the body or any other lymph nodes weren't involved. Yeah, yeah. Okay. So you would like to go with
So
topical, right?
yeah, topical followed by systemic. If no response, then straight away to systemic therapy for such a case.
Yeah, yeah, yeah. Okay. So, I mean, that's a right approach. I think, both of you had highlighted. So, in this case, actually, the lady has been on some kind of topical treatment, though it was not regularly, because as you were telling, it was shuffling between gynec and dermat for quite some time. She has been on some topical therapy for some time. So then that is the time, and the nodes were also there. So and again, clearly it wasn't malignant or inflammatory. So I just took a chance to start around steroids and weekly methotrexate, like somehow, like how we treat our own CTCLs. So this lady, we were able to taper steroids in 3 weeks, and then with weekly methotrexate, just, I think not more than 10 milligram or 12.5 milligram she tolerated. So that is what the dose we gave. And in two months time, the lesions became a bit of dry. And in 3 months time, we were able to completely stop steroids. Methotrexate, I think we did continue for some 6 months time, and then we completely stopped the treatment. And then just she comes, I mean, she never turns back to, I mean, she never turns back to hematology. She was just in follow-up with gynec. So that is what happened to this patient. And again, obviously, vinblastine and cladribine, though it was given as choices, it is, I think at that point of time, it was very difficult for me to convince the patient to take these therapies. Right. So maybe this is one of the case, very rare case. In fact, it was just as an opinion that came to me, but then he didn't take any treatment with me. So tough case. Maybe I'll ask tough master, Dr. Sujay. So this is a brain SOL. Okay. So the neurosurgeon operated, and the histopathology came to be Rosai-Dorfman disease. So the resection wasn't complete. It was an R2 resection. So Dr. Yeah, Sujay, what would you do?
Your slides are not moving.
Is it now it
Yeah, it's
is?
not moving, sir.
Now it is it
No, it's still stuck at differentials STD age related, like in Planus.
1 second, I'll just reshare. Yeah, now is it okay?
Yeah, yes.
Yeah,
So,
yes. This
got
was a
it.
brain SOL resected by the neurosurgeon. I mean, tried going in for resections, but the resection wasn't complete. It was R2 resection. The histopathology came out to be Rosai-Dorfman disease. So, how common is it RDD to have, and what would you do?
Yeah, so this looks like a quite extensive disease. So, like usually in RDD, if it is like a small, then it could be actually excised. So, excision is one of the treatment modality for the RDD, which are like localized. But I think this is an extensive disease, like you mentioned. So, in such a cases, I would say they should be definitely treated with the systemic therapy.
Therapy.
So yeah, so like you have like various options. Like cytarabine-based therapy, methotrexate, or if like in some cases you can also use targeted therapies also, like MEK inhibitors also you can use if you have access to those therapies. So they're one of the important modality for such a patient. If you are
Oh,
not able to do other therapies, then the targeted therapies are definitely and one option. Like even there are some paper like places like where you're given Redux plus steroids also as a combination therapy,
mm,
biologics. So
yes.
that's also one of the option. High dose Redux plus steroids you can use.
Okay.
Then like immunomodulators also you can use. If you're not able to use any other thing, then like immunomodulators also like one of the options. Uh, to be frank, I had only like one patient of this I had seen, and the
Mm,
patient had so extensive disease that we couldn't do anything for them, like for him except the steroids, and we lost
okay.
him unfortunately because it got too delayed. The diagnosis got too much delayed.
Yeah, so I think that's the main problem with histiocytic disorders. And it was a nodal or this kind of extranodal RDD, Sujay?
Yeah, it was the brain plus like
So it was brain plus node, is it?
so.
It was brain plus node.
Yeah, yeah, yes.
Okay, okay. Right. So again, it's really rare. RDD of nodes is what usually we do see in children. Most commonly said that maybe some of the common differences apart from Kikuchi, but CNS RDD is extremely rare. And since it's CNS, obviously you need to treat it like a high risk site. So where you can warrant use of MTX and cytarabine and small molecules are Dr. Sujay was contributing, like in case if you're not able to do this intensive therapies, you can go in for small molecules, right? So maybe that's the last case for the day. Yeah, so though it is an adult LCH, but we can have similar scenario in adult also. This was the last case, recent case to share. So he was a 1.5-year-old male child, weeping skin lesion over the scalp 3 months ago. But in 3 months, he presents to you with breathlessness, So the moment he is on, this much breathless, obviously he went and goes in for hypoxia, he gets arrested, he gets intubated, and he's already on ventilator, right? Okay, so now may I ask Dr. Jan, so how do you go about establishing diagnosis in this case?
Sir, I had a similar situation. This is in fact one of my relatives who was around 70-year-old. He
Okay.
had this kind of chest and a chronic smoker, but a reformed one. So I had this, I mean, typical CT picture. The only symptoms was just cough. That was the only
Okay.
symptom. And then had gone to a pulmonologist. Pulmonologist had done a CT chest. So one of the pulmonologists, he was not really sure what he was dealing with. The other one, he was because it was a 70-year-old, and the epidemiology of Langerhans is mostly it is 20, 30-year-old male smoker is the characteristic epidemiology. But that is when
Mhm.
I understood that actually sometimes it can present at any age. It characteristically at that age, but also can present in 60 to 70-year-old.
Mm.
A tissue diagnosis in this patient is very difficult. So, based on the history and the characteristic cystic CT findings, we just I mean, diagnose this as a possible Langerhans cells LCH, and then we just cigarette smoking cessation. And after that, serially CT showing, I mean, it's just been 1 year. 1 year later, CT showing some resolution, even though it's mostly static, but symptomatically much better. So I don't know how much we can chase tissue diagnosis in a case like this.
Okay, okay. So how was he treated? He was just observed, is it?
It was just smoking cessation, sir.
Smoking session.
So and with that, there was marked improvement.
Yeah, so that's I think that's an eye opener. So yeah, I think adult LCH. So that is the common thing, smoking cessation is the main thing. So since this being a child, so this was a
One
child.
minute. I
Yeah.
Yeah, for this child, this case we are discussing, he's having skin lesions as well, right, on the scalp, or it's only the
Yeah,
lung?
he is also having skin lesions on the scalp.
So then we can go for a biopsy from the skin lesion, which will actually give us the histopathological diagnosis if required. BAL might not be really
Mm.
helpful in this patient.
Okay, okay. So I'll tell you what happened with this child. Okay, this
Hmm.
child was not from here. So again, the skin lesions weren't very active. It wasn't weeping actually. You mostly you get a positive thing when you have a weeping skin lesion. That is when your positivity rates slightly go higher. Somehow this skin was already dry and it was actually post-inflammatory. It was just scarring. So skin wasn't contributory in this patient. So what happened is they, since already it was intubated, they just did a bowel lavage, okay? And in bowel somehow, again the diagnosis was not established in the center outside; it was established outside. So they did a bowel, and from bowel they, bowel and transbronchial lung biopsy. So that is how they established biopsy for this particular child. So then we came across a diagnosis of LCH, and again, maybe I'll just when CBC is normal, RFT LFT is normal. So do you guys routinely do bone marrow biopsy for child? On adult, it's different. Adults we don't do, but child do you do? In CBC is normal.
I'm not sure, but
Not sure.
I think if CBC is normal, then we may forego bone marrow.
Bone marrow, right? Okay, okay. So this right. So this is. I was supposed to put an image here, but somehow it got, I mean, I couldn't get the image. So What happened? Yeah, so that's what with the biopsy, as Dr. Venkat was telling, skin is the whatever is visible, that is the easiest site to do. And if it is undergo some scarring or some inflammation, then when the child is already intubated and ventilated, then getting a BAL or you getting a transbronchial lung biopsy becomes easy. But what was very problematic with this child was, he kept on, when we are ventilating, he kept on developing new bullae side by side. So you're actually not able to differentiate whether it was bulle due to ventilation or bulle due to disease. So somehow this child got treated with already before being referred. He was already getting 4 doses of vinblastine and steroid. 4 doses of yeah. So 2 weeks of vinblastine and steroid. He has had progressive bulle, ventilated, not maintaining saturation, and he also developed a bloodstream infection with Serratia Kingella, and he also had some CMV viremia. So now maybe you may ask, Dr. Sujay, like, what do you want to think or do at this point of time when you have such difficult to manage patient and if you have an aggressive pulmonary LCH, what do you want to do? All the panelists can give the answer, like your thoughts.
Yeah, actually, to be frank, I've never seen pulmonary LCH. I've seen a lot of LCH, a lot of relapsed refractory LCH, but
Mm-hmm.
not particularly pulmonary LCH. I don't know.
Okay.
Maybe I would go with targeted therapies if possible, if you're not able to do steroids or anything.
Mm.
So, and
So that's a correct.
like, is there a role of any?
Uh,
Yeah, please.
yeah, tell Sujay, tell Sujay.
No, no, just go ahead, go ahead.
Yeah, okay. So maybe I'll just come to all panelists and then tell
We had
Venkat, you want to?
encountered a similar case, a child with pulmonary involvement and systemic infection. So basically, child was was in pediatric ICU for nearly 20 days. Post that, the diagnosis was delayed because BAL could not be performed at that point of time.
Okay.
And later on, it was just because biopsy was non-contributory, we just thought it could be a possibility of LCH was kept because of the skin lesions and because of skin biopsy was done twice. And then under the cover of antibiotics,
What did your skin biopsy turn out to be, Harshal? Like, did it come positive?
no, sir. It
It
was
came negative,
non-contributory.
right?
Yeah.
Yeah, this patient also had a similar trouble.
Yes,
I
sir. It was repeated twice, but it was non-contributory. And
okay.
when we sent BAL also, it was non-contributory. Like we did not get anything definitive. So
Okay.
we even did a bone marrow because there was cytopenia, but that was probably non-specific because of the underlying infection, DIC going on at the same time.
Okay.
So we just under the cover of antibiotics started him on low dose steroids and targeted therapy vemurafenib. Though we did not have a molecular diagnosis of
Mm.
BRAF positivity, vemurafenib was started, and post starting of vemurafenib, child showed significant improvement actually.
Improvement. Yeah.
Yes,
So similar
and was
experience
extubated eventually. Yeah.
eventually.
And
Yeah.
one patient, I think probably you might also be aware of, sir.
Uh-huh.
Probably during your residency, a child had received induction therapy with vinblastine and steroids,
Okay.
and later was admitted with pulmonary LCH. His name is Kunj actually. So he was admitted
Uh,
with pulmonary involvement, skin involvement, and marrow involvement. So initially was started on cladribine, cytarabine therapy, but was having did not have remission. In fact, resistant cytopenias with
okay.
fulminant infection. He had disseminated aspergillosis.
Oh.
So was subsequently started on vemurafenib and is still in our follow-up post 3 years now, 3.5
And we
years.
have been unable to stop vemurafenib. So I
Yeah,
wanted to know, in this child's management, it will be easy to start vemurafenib, but there is no data to either shift to systemic therapy after bringing him out of this acute condition, or whether to continue vemurafenib indefinitely.
Uh,
Okay.
So
mm, yeah. Ma'am, actually, we had reviewed literature extensively because of this guy only. But the thing is, actually, what they say is until unless you give targeted therapy will mainly cause the suppression of the pathway. So it will
yes,
effectively not
you
eradicate
can't
the
stop
clone.
it.
Yeah.
The
So what
risk of
is,
relapse is more than
yeah,
like
yes,
60% if you stop it.
if you stop it. So what this is, you consolidate again with
Well,
cladribine, cytarabine, you eradicate the clone and then maybe taper off and stop. but I do not know how, like in a child who is asymptomatic at that point of time, whether giving consolidation would be appropriate and pushing more of chemotherapy related toxicity. So
Right.
need your opinion on this actually.
Yeah, yeah. Okay. Maybe I'll ask panelists inputs, other panelists inputs, and then I tell what I did with this child. Venkat, John, your inputs, how difficulties you have had in managing these patients, your own personal experiences you can share so that we'll all learn.
So I will,
Personally, yeah, John, carry on.
Yeah, Venkat, Venkat,
Venkat
go
sir,
ahead.
please continue.
Yeah, yeah, okay. So personally, I have seen only one patient with pulmonary LCH, but it was in an adult, and he had this multiple bullays, but he just responded beautifully to cyclaven. So
Okay, okay.
like, but and we had to just give him like cyclaben, and after that we had stopped the systemic therapy, and there was a resolution of the CT findings, and he is I followed him up for nearly 1.5 years after that, and he's still asymptomatic, and one repeat CT was done after a year, which showed no any relapses so far. Other than that, pediatric with pulmonary this extensive, personally, I have not seen any patient.
So cytopin you did for 6 cycles, is it, Venkat?
6 cycles, yeah.
6 cycles. Okay, okay. So the decision to start cytopin was based on um,
We had a tissue biopsy proven from the this one lung biopsy has was, yeah.
okay, okay. Yeah, John,
This
you were
was
thinking?
Dr. Venkat just had a doubt. This
So
patient was a smoker or like was it
he
a
was a no, he was a smoker, but cessation of smoking there was no much resolution, and he started becoming symptomatic later. It was Dr. Udai's patient, which we had followed up, and then finally Dr. Uday decided
okay?
to start on cytarabine, and with that he actually responded very well.
So that is what I wanted to ask.
Okay.
How much time do you take to decide whether to start something on? That is a main catch, right? What was the time point that you guys wait
This
for?
patient actually, it was, if I remember, it was during my third year in my residency. So he came as he was never admitted or anything. It was just progressive cough, and CT findings suggestive of recurrent pneumothoraxis bulle. And then finally, the pulmonology had decided to do a biopsy from the lesion, and then proved it as LCH. And after that, he was a smoker. Smoking was stopped. He was followed up for next 3 months. But he had another episode of pneumothorax, spontaneous pneumothorax within the next 3 months. Got an ICD inserted, removed, and then he came to us. So even after stopping smoking, and he had like this repeat episodes. So then we decided to start on cytarabine.
Okay, okay, okay. Nice, nice, nice. Okay. Anybody else wants to share their own experiences? Archit, maybe you can take the final lead and I'll close it.
Nothing to add, Gopi. Thank you.
Okay. 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 So
Actually, I wanted to ask one thing. Because I had seen in children, though I had seen like good remissions, but in adults, I had seen like many patients tend to keep on relapsing after various therapies. Vemurafenib, though we had used only for one patient, and that too after 1 year, that patient has stopped using it, and then
mm,
he had relapsed. Then I couldn't follow up. So like right now, I have one patient which I'm treating adult patient around 40-year-old. So he had he presented with SAIDH basically. So that's a we like he was diagnosed as LCH. So he had SAIDH as hyponatremia persistently. Then after that he took steroids at another hospital. Then he had a lot of symptoms because he already had like endocrinopathies. So then that was stopped. He missed. Then he relapsed again. So after this 2 cycles of Vinblast and steroid. So now I'm giving him cytarabine plus pamitonate, which I had used previously also in another in like other such patient, and we had like good response with cytarabine plus pamitonate like
mm,
150 mg per meter square cytarabine 5 days a month plus pamitonate.
right.
So, like you mentioned, like John has mentioned that I also have read it should be given at least for a 1 year. So, but like in my experience, in whatever patient had given cytarabine, though we got remission, they again relapsed. So I
Yeah.
feel this patient they tend to have like chronic form of diseases once they start relapsing. So like, so what do you feel should be a way forward to treat such patient? Definitively, should we offer them some other option? I don't know if transplant or something. Like how do
Mm.
you face such situations when you're having such patients?
So the relapsed refractory, I can find some data on hydroxyurea and lenalidomide. IMiDs are also a good go-to agent when they relapse. And obviously, when you use cytarabine, you have the other next drug. Cladribine is one drug which you can consider using. And IMiDs have got a reasonably, good working role in relapsed LCH. IMiD versus hydroxyurea. So that is what you have maximum. And ultimately, if you're able to prove targeted mutation, you can do targeted therapies. And now there is a paper when I'm reviewing literature for this guy, this guy didn't have BRAF positivity, but still, for this patient, this child in the index patient, since he had so much troubles and we were very finding it very difficult to proceed with vinblastine prednisone, we did a combination of dabrafenib and tramitinib. So dabrafenib at 5 mg per kg, and I think tramitinib was 0.35 mg per kg. So almost, I think it took 3 to 4 months. It didn't resolve immediately, but it took almost 3 4 months for the pulmonary disease to resolve. So now almost I would say the chest X-ray is looking like nearly 80% normal. So till this time he was on ventilator. He was tracheostomized, he was ventilated, he was taken care properly by a cardiac team, cardiopulmonary team, and then now the lung almost looks normal. So initially they were thinking whether should they do a lung transplant, this, that, or not. Now we are thinking now that, as you all say, molecular treatment is not the definitive one. It just suppresses the pathway. Probably when he gets fit, we will continue the rest of induction, maybe in that LCH4 protocol, for those guys who haven't responded induction, we will put on that protocol and then close the treatment is what we were saying. But as Sujay was asking, if you have a relapsed LCH, if you already use cytarabine, second option is Cladri, then we have reasonable data on use of hydroxyurea, MT and lenalidomide. And obviously target therapy, I think this can be used. Nowadays, we have data for non-BRAF V600 positive, though the response rates are slightly lesser, where instead of vemurafenib, we can use a combination of dabra and tramitinib. Even cobimetinib is coming up for non-BRAF 600 positive cases.
How much
So,
did it cost, sir? Just
uh,
out of curiosity. How
cost,
much was the cost for this combination
cost
therapy?
actually, cobimetinib is costly, but Dabra and Trami was not that costly compared to the illness that that this guy is having, and he was spending on ventilator, infection, this, that. Cost wasn't that that high. Though I mean it is expensive, but not so much of expensive. Maybe exact cost I'll message you, Purvi. I'll check and message you.
Sure, sir. Thank you.
So, sir, just one doubt. So essentially, I mean, we can say that very critically ill LCH, we can perhaps to tide over that crisis, we can try targeted therapy, and once they're stable, you can go to a cheaper systemic therapy option. Is that what we?
Logically sounds good, but I think even in children, definitely the mainstay is chemo. Even though they look sick, again, still the injection of choice is steroid and vinblastine. Maybe if they have something like this, active bloodstream infection coming up, active CMV virus or something of this sort, maybe this is one of the rare scenario where we can go in for targeted therapy. But then traditionally these LCA children somehow when till the waiting time for diagnosis, if they are still sick, guidelines still say you should go ahead with the routine chemotherapy. In exemplary scenarios, I think this target therapy worked for this particular patient. So I think now that I can say yes, it may actually.
Oh, okay, sir. Thank you.
Both the onset of
JP, given that
response.
it is a inflammatory disorder, does IVIG help in any of the situations, or is it like
I'm
other inflammatory disorders, IVIG does help? So
I am not aware, Arshit, and or neither I haven't given. I mean, I don't remember giving also. I don't. Maybe I have to after you asking, I have to just think. Can you suggest something? No, I don't know the answer for this.
no, I was just asking. You have the most experience. You have 5 cases presented, and think
No, these were what to say. Uh, okay, so I think so. This is the last case for the day. So with this, I stop sharing my screen. Thank you so much, panelists, for being with us, till 8:10, and it's almost going to be 8:20. So if any others want to add anything or ask any questions, please.
Gopi, there will be some histiocytic disorders in which, I mean, as we always try to confirm the diagnosis, whether it is a malignant or a benign disorder, even when a lab reports increased histiocytes,
Mm,
I've heard this in one of the talks that we should always try and understand whether that histiocyte is a clonal histiocyte or a part of a reactive histiocyte.
mm.
So if it is a clonal histiocyte, then we think in terms of these histiocyte disorders. If it is a reactive histiocyte, then we think in terms of something like inborn errors of immunity or some other trigger which is causing the histiocytes and macrophages to come in. So
Mm,
just because a lab is reporting histiocytosis
mm.
should not make us think all the time that it is malignant histiocytosis.
Just right.
So we should always try and think what is the microenvironment, are monocytes there, are clonal markers present. I know it is difficult, but
Mm,
as a algorithm, we should always try to get it whether they are clonal or non-clonal with the markers which John has told us. So there can be lymph nodes, there can be disease processes, especially some autoinflammatory type of diseases, which can have histiocytes as a part of chronic inflammation. So if we keep chasing in those disorders for LCH, we may miss them. So on a IAP PHO education group, there is a case which I will share in the group. You can share amongst all, wherein they
mm.
presented a case from a United States, wherein this analogy helped useful. So I'll search
Perfect.
and put, but that is one take-home message I'd like to tell.
Thank you so much. Thank you so much.
Thank you, sir.
Mm, okay. Yeah.
Thank
So
you, sir.
thank
Great
you.
discussion.
Thanks for
Thank
having
thank you
me.
guys. Thank you, sir.
Thank you so much.
Thank you, sir. Thank you for excellent presentation. So, as we come to the conclusion of today's enriching session, I would like to invite our program director, Dr. Gopinathan M, uh, to share the concluding remarks. Over to you, sir.
Yeah, and I think we had a enlightening discussion and inputs from all the panelists. They have stayed till almost close to 8:20 to contribute their valuable insights. John did a wonderful job of compiling the big guidelines on adult LCH, and I think we all agree that it's very rare in adults. It's very difficult to manage, and particularly when the patient comes to you with a lot of morbidities, clinical symptoms, to decide which step to move forward is a difficult decision, though we read on textbooks. So I think hopefully this session may be just a starter session to initiate insight and keep discussing on such tough cases in the looking forward to this similar kind of meetings in the future session. Thank you once again.
Thank you, sir.
Thank you so much, sir, for those valuable concluding remarks and for guiding today's insightful scientific program. So, on behalf of the International Association for Integrated Oncology, I would like to extend our sincere gratitude to all our distinguished faculty members for sharing their valuable time and knowledge and clinical experience. Our heartfelt thanks to all the participants for joining us and contributing to the success of today's program. With this, we conclude today's IIO Expert Insights Hemato-Oncology session. Thank you, everyone. Have a wonderful evening ahead. Thank you. Good night.
Good night.
Thank you, Dr. Gopi and IIO. Thank you so much. Thank you all for joining. Good to meet you virtually.
Thank you all.